Yeah, good evening, my dear doctors. Good evening, Dr. Anush Kumar Chaudhary. Good evening, everyone. I hope I am audible and visible, so everything is fine. So in this NEET PG T20 series, it is not only 20 MCQ discussion, but we'll try to discuss a lot of topics which are important for your upcoming NEET PG. So starting with the first question, as we have seen for last 3 years, a lot of questions are coming from special sciences, especially the taste. Okay, so taste will be absent in which taste bud? Filiform, foliate, which are important for your upcoming EPG. Fungiform, just a minute. So starting with the first question, as we have, or circumvallate. Yes, what is your answer? Answer is A. Very good. Answer is A. You know that filiform. So let me discuss few more points which can be asked in the further examination about the taste. So approximately 8,000 to 10,000 taste buds are on the papilla of the tongue. So we must know there are various papilla in which foliate, fungiform, and circumvallate have taste bud. In filiform, taste buds are absent. Okay, in filiform, taste buds are absent. So approximately how many taste buds are there? 10,000. 8,000 to 10,000. Okay, and where are they located? So they may be located in the soft palate, epiglottis, and phalanx, and also you can see in the tongue. In the tongue, there can be circumvallate papillae on the posterior side. On the anterior side are the fungiform, and here it is the foliate papillae. So foliate, circumvallate, and fungiform papillae. In one fungiform papillae, we have 5 taste buds. 5 taste buds are there in one fungiform. Okay, and 100 taste buds are in one circumvallate papillae. On the other hand, again 100 will be on the foliate. So we can see, although minimum there are 5 taste buds per papillae in fungiform, but you can see the location, they have maximum taste bud because of the location. They are present on the anterior side of the tongue. Now, if you see about one taste bud are having epithelial cell, taste cell, basal cell, and these are the sensory ganglion. So these are the sensory fibers which are taking the taste sensation from taste pore. And this is the saliva from von Ebner gland. It is from von Ebner gland, the salivary duct, the salivary gland. It is helping you in perception of the taste. So mainly it is helping you in perceiving the taste. Now we can see what are the important points which need to be remembered regarding taste bud. So how many cells are there in the taste bud? So morphologically distinct, there are 4 types of cell and they all are morphologically distinct. Like they are the basal cell, they are the dark cell, light cell, and intermediate cell. So basal cells are located at the base. You can see in this diagram, basal cell is located at the base. And these taste cell can be of 3 types, type 1, type 2, and type 3. Type 1, type 2, type 3 are also called as dark cell, light cells, and intermediate cells. These are referred as type 1, as I have told you. Basal cells called as simply basal cell, dark cell type 1, light cell type 2, and intermediate are called as type 3. They are having the sensory neuron that respond to the taste stimulus or the taste sense. Each taste bud have between 50 to 100 taste cells, and the 3 cells types may have various stage of differentiation. And sometimes they ask you in the examination, out of these 3 cells, which is the most mature of them? Answer is the light cell. So light cell among all, I mean dark cell, light cell, intermediate cell, the mature one is light cell. And from the anterior part of the tongue, these are carried by chorda tympani, branch of facial nerve. From the posterior side, you can see they are taken by glossopharyngeal nerve, and rest all will be taken care by the 10th cranial nerve. You can see here 10th cranial nerve. So 7th nerve, 9th nerve, and the 10th nerve are the sensory fibers, and they will modulate the taste in which nucleus? What is the name of the nucleus? It is nucleus tractus solitarius. Nucleus tractus solitarius is present in the medulla. It is present in the medulla. It is called as taste integration center. And of course, the relay station is the thalamus. Yes, Ajay, image, can you see now? Can you see the anterior part is taken by, yes, chorda tympani. Posterior one is taken by glossopharyngeal and rest taken by the vagus nerve. They will all, okay, now it's clear. Okay. So they will be integrated in nucleus tractus solitarius and in the thalamus. Which nucleus is the relay station? Answer is ventro-posterior medial nucleus. Normally, we always remember VPL. Normally, we always remember VPL, but it is having VPM. M. Remember meetha, taste. L is for dorsal and anterolateral. And for taste, we have VPM. Okay. And ultimately, they will relay to the center called as gustatory cortex or anterior insula, frontal operculum. Every step is a point. So, number one, the anterior tongue will be carried by chorda tympani branch. Posterior will carry by glossopharyngeal nerve. Rest all will be carried by the vagus nerve. They will ultimately relay in the nucleus tractus solitarius. Now they will reach in the thalamus. Which nucleus of the thalamus is the relay station, my dear doctor? It is VPM. VPM. And where in the cortex? Again, answer is anterior insula frontal operculum. So a lot of questions nowadays are based on the taste sensation. So this is the must, they are the must point which you need to remember. Now again, one more question from the latest INSTT examination. Sour taste is mediated by TRPP3 channel, metabotropic channel, GPCR T1R1 or GPCR T1R3. So let me ask you how many of you are correct with this question. Let me see. Although this question, the answer, exact answer is even not in Gano. But even if you know the exact answer, if you don't know that, even then you can solve it by ruling out other options. Yes, SS, your answer is A. Very good. Anuj, also answer is A. Excellent. Answer is A. See, you know there are how many types of taste? Out of all taste, salt and sour. Salt and sour, they are salt and sour. They are based on ENaC receptor. ENaC is epithelial sodium channel. Rest all are examples of G protein couple receptor. It can be sweet, it can be bitter, it can be umami. So we know that sour taste is not G protein couple receptor. So answer you can rule out GPCR. And G protein couple receptors are type of metabotropic receptor. So answer is not B, C, and D. So by ruling out, you can say answer is A. But because now they are asking these types of question, you must know the exact detail of the taste. So we can see this image from Ganong, salt and sour. Salt and sour, they are based on epithelial sodium channel and SCN channel. Rest all like sweet, like bitter, like umami, they all are type of metabotropic receptor. Metabotropic receptor, or simply we can say G protein couple receptor. G protein couple receptor. So out of these, three are metabotropic. Please don't forget, nowadays these are very high yield topic. The taste, the types of taste receptor. Salt and sour are ENaC. Rest all are G protein couple receptor. You also need to remember which type of GPCR. So sweet is number one. So T1. Sweet is number one. You can remember like T1, T1R1, T1R2, T1R3. So T1, just remember T1, you can solve the MCQ. Okay. Now T2, T2 is bitter. You know T2, T2 Mama, the famous the episode. So T2 is bitter. T2 is bitter. Okay. And about umami, umami is usually in the some meat or some Chinese food. The taste, it is based on the glutamate receptor, so called as metabotropic glutamate receptor. Metabotropic glutamate receptor. Till date, this much has been updated in the genome. But this time they have asked about exact sour receptor. So we have taken the help of other physiology book with the name of boron, and we can see now exactly how salt and sour are behaving. Exact what is the name of the receptor that they have asked in the examination, and then you will come to the answer TRPP3 channel. This is the exact name. So now, because they're asking you more detail of the sour taste, you must know this topic in detail. Answer is TRPP3. Even this time in the INCT, if you have seen, questions were often from repeated MCQ only. Repeated topics, not the MCQ. So they keep on asking the same topic. So because for last 2 years in the NEET PG, they are asking about the taste. So please remember what are the other channels. So we know they are ENaC. We know they are epithelial sodium channel. But exactly what is the name? TRPP3. The name of the channel is TRPP3. When sodium will come inside, it will cause depolarization, causing influx of calcium, and calcium will release neurotransmitter for the taste perception. Is this clear? For sweet, umami, and bitter, they all are variety of G protein coupled receptor. You can see GQ receptor, calcium is released, and calcium will cause exocytosis of neurotransmitter. So both are through calcium, but one is by opening the voltage gated sodium channel due to depolarization. Other is example of G protein coupled receptor. So I hope you are not going to forget the answer TRPP3. Now back to the question. Now exactly you know that GPPR T1 are based on the sweet, metabotropic is a variety of GPCR, and TRPP3 is the exact name of sour taste receptor. I hope now you will not forget this. I will not take much of your time because your time is very crucial for the exam. So I will try to revise a lot of content in 1 hour. Okay, the next question is RMP predominantly affected by which ion? Now, again and again, we know this concept about the RMP. Even then, because of we are in hurry, we are in stress in the examination, we try to make mistake. So we will discuss all the questions which has been asked in last 5 years regarding RMP. So RMP predominantly affected by which ion? Sodium, potassium, calcium chloride. What is your answer, doctor? And don't hesitate in answering. Even if you're wrong, no problem. In the exam, you should be correct, not in the discussion. In the discussion, if you're wrong, definitely you will not repeat the same mistake in your exam, isn't it? So SS is saying potassium. What are the other answer, please, doctor? Potassium, calcium, sodium chloride. Resting membrane potential is predominantly affected by which ion? It is due to which ion or affected by which ion? Which is the most important ion for the life? It is potassium, my dear. RMP means life. RMP is resting membrane potential in all living cell. Resting membrane potential in all living cell. And that is because of potassium. That is why when there is a hyperkalemia or hypokalemia, heart can stop. Why? We are very much worried about the potassium level, even more than sodium. Why? Because RMP is due to potassium, not sodium. This is the correct answer. Now, what are the other things which you need to remember? So, what is RMP? Resting membrane potential is the voltage difference across resting cell membrane. Usually minus 70 millivolt in neuron, minus 90 millivolt in skeletal muscle. So if there are two electrode, one inside, other outside the cell membrane, there will be a potential difference, and that is called as resting membrane potential. And this is due to which ion? Potassium, potassium, and potassium. Please don't forget this. Hyperkalemia and hypokalemia, they are dangerous. Why? RMP is due to potassium. It plays the most critical role, as membrane is most permeable to potassium, not to sodium. At the resting condition, your cell membrane are permeable to potassium. Potassium can go out. Sodium cannot come inside, my dear doctor. Sodium is not permeable at resting condition. Only when there is a stimulus. Only when there is a stimulus, it becomes permeable. So for action potential, sodium is important. But during resting condition, sodium is not permeable. Only potassium is permeable, my dear doctor. So when potassium is coming out, This will be negative charge. This will be negative charge. So who generate RMP? Answer is potassium. But if they ask you who maintain it, who maintains RMP, then answer will be sodium potassium pump. My dear doctor, please remember, sodium potassium pump is not generating. It is maintaining the RMP. And you can remember by the mnemonic Nokia. Nokia. Sodium out, potassium in. What is the ratio? 3:2. 3 sodium out, 2 potassium in. It maintains the gradient. So inside will be negative. So Nokia is sodium out, potassium in with the help of ATP. Ratio is 3:1. Okay. Now, next point which can be asked. RMP of various cell type. Neuron has -70. Skeletal muscle has -90. Cardiac muscle has -90. SA node has -60. So these are the four which you have to remember regarding RMP. Now, threshold potential remain unchanged. So any shift in RMP affect the ease of reaching it. Threshold potential remain unchanged. RMP can be changed. So how? Remember, my dear doctor, in hyperkalemia, RMP become less negative. In hyperkalemia, RMP become less negative. In hypokalemia, RMP becomes more negative. This is the crux of why there is ECG differences in hyperkalemia and hypokalemia. See, RMP is due to potassium efflux. You know that point. RMP is due to potassium efflux. If there is hyperkalemia, potassium efflux will be more or less. If there is hyperkalemia, potassium efflux will be less. So RMP will be less negative. On the other hand, if there is a hypokalemia, more potassium have to go outside to generate RMP. So RMP will be more negative. This is coming in almost every NEET PG and we are making mistakes. Is this clear, doctor? Disturbed RMP will impact the nerve conduction. We know that. Now, in hypokalemia, I told you already, RMP become more negative. Cell become less excitable. In hyperkalemia, RMP become less negative. So both will cause decrease in the excitability. Decrease in the excitability. And if you remember the ECG changes in hyperkalemia and hypokalemia, in hyperkalemia, remember the mnemonic is PQRST. The mnemonic to remember, hyperkalemia is PQRST. P is absent. In hyperkalemia, P is absent. QRS is wide. And T will be tall and dented. Tall and dented. Okay. So what are the ECG changes in hyperkalemia, doctor? P wave will be absent. QRS will be wide and T will be tall dented. All the three features of hyperkalemia. Regarding hypokalemia, the mnemonic is stupor T. Stupor T. Okay. ST wave depression. U wave PR will decrease and T wave will be inverted. Stupor T. So initially they were asking only about T wave, tall T wave hyperkalemia and inverted T wave hypokalemia. But now they are asking exactly what are the other features. Okay. Which of the following hormones have intracellular receptor? Thyroxine, glucagon, epinephrine, or parathormone? What is your answer? Again, there are two types of intracellular receptor. Yes, doctor, what is your answer? Thyroxine, glucagon, epinephrine, or parathormone? Yes, very good. Answer is A. And glucagon is G stimulatory. Epinephrine again GPCR. Parathormone is again GPCR. So answer is definitely A. So most of them are GPCR, you know, except few. Please revise about that. receptor tyrosine kinase. What are the example of receptor tyrosine kinase? Answer is insulin plus all growth factor except TGF beta. They are example of receptor tyrosine kinase. Second is tyrosine kinase associated receptor. Okay, they are growth hormone plus 14. 14. One is prolactin, erythropoietin, thrombopoietin, and leptin. Now coming to the intracellular receptor. You are very correct, Dr. Anuj. You are correct. There are two types. Type 1 intracellular receptor and type 2. Exactly, you must know example of type 1 intracellular receptor. They are also called as homodimer because they form homodimer. So they are also called as homodimer receptor. Type 1 intracellular or homodimer receptor both are same. And the location before the binding of the ligand is in the cytoplasm. And what are the examples of type 1 intracellular receptor? All the steroid hormone. You are correct. Glucocorticoid, aldosterone, testosterone, estrogen, and progesterone. Not thyroxine. Thyroxine will come in type 2. I will tell you that. So in type 1, most of the steroid will come and their location is, where is the location? Inside the nucleus or in the cytoplasm before binding? Answer is location is in the cytoplasm. This is your nucleus, DNA, RNA, and all those things. And this is the how ligand will come and bind with the cytoplasmic receptor, and they will form homodimer. Clear? That is why type 1 is also called as homodimer receptor. Now, how they will work? What is the exact mechanism? See, this is your cell. This is the nucleus. Nucleus are having DNA. DNA will make RNA and all those things. And this is your beautiful cytoplasmic receptor. Now, when ligand enter inside the cell, the first step is what? Ligand enters the cell and bind the receptor in the cytoplasm. So ligand will bind with the receptor. The first step is ligand will bind with the receptor. Okay. The receptor is initially bind to heat shock protein. Which protein? Heat shock protein, also called as chaperone protein. This is very important topic I'm going to tell you. This is a topic which is coming again and again, and we are tend to make these mistakes. So even before ligand come inside the cell, cytoplasmic receptor are binding to heat shock protein. Why? To make them inactive. Why? To make them inactive. What is the answer? Why you need chaperone protein? Why you need heat shock protein? To make them inactive. Otherwise, they will enter in the nucleus, activate the DNA without the ligand. Now, without the ligand, your receptor need not be activated, my dear doctor. It need to be activated only in the presence of hormone. The receptor is initially bound to heat shock protein to make them inactive. When ligand binding will happen, it will cause dissociation of heat shock protein. So it will dissociate the friendship with the chaperone and it will form homodimer. It will dimerize. It will form homodimer. The third step is what? Dimerization of the receptor. Dimerization. Hetero or homo? Homodimer. After dimerization, this will translocate to the nucleus. Now this will translocate to the nucleus and bind to the HRE. HRE. Bind to the hormone response element on the DNA and then regulate gene transcription. Why I'm telling you this detail? Because this is a topic which is often repeated for NEET PG and NSET. So I hope you can recap now. There are two types of intracellular receptor, type 1 and type 2. This much is clear. Type 1, they have ligand of all the steroid hormone. It can be aldosterone, estrogen, testosterone, and all those things. Type 1 hormones are receptors are also called as homodimer. What are the steps? So ligand enters the cell. Step number 1, ligand enters the cells and binds the receptor in the cytoplasm. The first step. Number 2, it will remove heat shock protein, which is also called as chaperone protein. Chaperone protein. Next MCQ. What is the need of chaperone protein? What is the need of heat shock protein? The need of heat shock protein is that to make the receptor inactive. Otherwise, even in the absence of hormone, it will go inside the nucleus and activate the DNA, RNA, and protein. It should not happen. Only when ligand in the form of hormone enter inside the cell, it will dissociate the chaperone, forms dimer, translocate in the nucleus, enter and bind with the hormone response element and regulate gene transcription. So this is the exact mechanism given in Harper and Ganong, which is asked again and again in INSCT NEET PG. I hope you should not forget. There should not be any doubt. It is a common question for physio, biochemistry, and medicine. In type 2 receptor, type 2 intracellular receptor, location is before ligand binding in the nucleus. Now, this is the cell. This is the cell. And suppose this is your beautiful nucleus. I will make it bigger so that I can explain you. Otherwise, it is not that big. Only for convenience purpose, I am making it. And the receptor is in the nucleus this time. Receptor is not in the cytoplasm. This time, the nuclear receptor is located in the nucleus. Okay, that is why they are called as nuclear receptor, type 2 intracellular receptor. What are the examples? Examples are thyroid hormone, your question. Vitamin A derivative, right? Retinoic acid, RXR. Then vitamin D, again repeated MCQ. Vitamin D is the example of type 1 or type 2? Type 2. Because nucleus is having the receptor inside it. Then we have PPAR alpha and gamma. PPAR, PPAR alpha and gamma. Alpha agonist and gamma agonist. Alpha agonist is fibrate. Alpha agonists are fibrates. They are given to reduce the triglyceride. And gamma agonist is pioglitazone. It is given in diabetes patient. And if they ask you dual agonist, alpha and gamma, dual agonist, it is your Saroglitazole. So PPR alpha and gamma, they are also type 2 intracellular receptor. Now, how exactly they will work? First, remember the ligands. What are the ligands? Thyroid hormone, vitamin A, vitamin D, and PPAR alpha and gamma, and where they are located in the nucleus. Now, how they will work? How they will work? This is your cell again. This is your nucleus again. It is not that big, but I'm making so you can understand. Inside the nucleus, we have nuclear receptor. Receptor is already in the nucleus bound to DNA. Now, DNA is very close to the nucleus. Now, there is a risk of activation of DNA without the ligand. There is always a risk. So, who will make it negative? NEET PG question. This is a NEET PG question that when receptor is in the nucleus, who will make it an inactive receptor? Answer is it is associated with co-repressor protein. It is always associated with a protein, and that protein is called as co-repressor. You should not forget this. Co-repressor protein which make the receptor inactive. Now, the ligand will enter in the nucleus and bind the receptor. What is the first step? Co-repressor is released. Co-repressor is released and they will form heterodimer. They will not form homodimer. They will combine with RXR. They will combine with RXR and activate the transcription. So please remember they will form heterodimer, not the homodimer, but heterodimer. So this is about type 2 receptor in the cell. Examples are thyroid hormone, PPAR gamma, and alpha, as well as vitamin D. Now next question. Now this is the summary. Okay, this is the about heat shock protein, chaperone protein, and this is about the core repressor will inhibit that and it will activate. It is the same thing which I have discussed. Now, in negative feedback, feedback gain is infinity in which of the following? What is your answer? In negative feedback, feedback gain is infinity in which of the following? Temperature control in hypothalamus, blood volume controlled by the kidney, blood pressure controlled by pyroreflex. No such infinite feed gain is impossible, not possible. What is your answer? Yes, John, your answer is B, absolutely correct. Blood volume controlled by kidney. Very good. Absolutely correct. See, gain is equal to correction upon error. You are absolutely correct, doctor. Whenever error is zero, gain will be infinite. Whenever error is zero, gain will be infinite. So again, a very hot topic for NEET PG. So feedback, body senses the changes and react to correct. It can be negative, it can be positive. So when we sense some change and try to correct, it is the physiological mechanism. So it is called as negative feedback. It opposes the deviation. Suppose BP is high, it will make it low. Pulse is high, it will make it low. And that is called as negative feedback. It is the most common in physiology because it is trying to regain the homeostasis. Suppose you are doing exercise, your BP is 160. After 15 minutes, it will come down. It is negative feedback. On the other hand, positive feedback amplifies the change. Suppose my BP is high and some receptor is making it higher and higher. Or in the shock, if BP is low, it keep on making it lower and lower. It becomes pathology. It is called as positive feedback. So usually positive feedback are pathological except few examples. Now, what is gain? Gain is equal to correction upon error. Higher is the gain means better is the correction. Lower is the gain means lower is the correction. Infinite gain occurs only when system completely correct the error. So error is zero. Only when error is zero, gain can be infinite. And the example, as you know, kidney water correction, osmoregulation is the example of infinite gain. This is asked again and again. The water correction by kidney, osmoregulation. Why? Because when plasma osmolarity rises, kidney adjusts water reabsorption perfectly to restore osmolarity with no residual error. On the other hand, when BP is high or BP is low, pyroreceptor reflex also have high gain but not infinite. So our BP regulation is also good. It has high gain but not infinite. What is the clinical significance of the gain? Infinite gain means perfect control. Low gain means failed feedback, like the disease like diabetes insipidus. Positive feedback are the example of, for example, labor contraction. The mnemonic is claps. The mnemonic for positive feedback is claps. C for clotting. L for LS surge. A for action potential. P for parturition. S for shock. So these are example of positive feedback mechanism. So these all are feedback, not feed forward. Temperature regulation, which is given in your one of the option. This is example of feed forward. Feed forward. So whenever you are working in anticipation, for example, if you go to cold climate, even before your temperature changes, you start shivering. So that is called as feed forward. Temperature regulation and cerebellum working is the example of their example of feed forward, not feedback. Okay. So next topic, 65-year-old male patient visited to ER for chest pain. His BP was measured at systolic 190, 100 diastolic. Yes, Anirudh, head paradoxical reflex. Very good. Very good. Paradoxical head reflex. Inflation causes further inflation. When child is crying for the first time, the newborn crying for the first time, inflation causes inflation is an example of positive feedback. Okay. So pulse pressure is 90. Which of the following parameter that should decrease for this high pulse pressure? Tell me. What is the answer? Arterial wall compliance, stroke volume, cardiac output, myocardial contractility. Which parameter should decrease? So pulse pressure should increase. Pulse pressure is proportional to the stroke volume upon compliance of arterial wall. If you know this much, you can solve all the questions. So if stroke volume is high, pulse pressure will be high. Cardiac output is high, stroke volume is high, again, pulse pressure will be high. But if compliance is less, only then pulse pressure will be high. And if you have seen the 5-year paper, NSCT and NEET PG, pulse pressure is a topic which is coming every year. So we must have a detailed discussion regarding pulse pressure. So what is pulse pressure? First of all, it is systolic BP minus diastolic BP. Okay. Stroke volume. Increase in the stroke volume will increase pulse pressure. Increase in the stroke volume will increase pulse pressure. Like fever, anemia, hyperthyroid. So whenever there is a thyrotoxicosis, whenever there is anemia or fever, so all those conditions, when your stroke volume is high, pulse pressure will be high. On the other hand, decrease in compliance will increase pulse pressure. It is inversely proportional. So aging, arteriosclerosis. So when we start aging, stiffness will happen. Okay, stiffness will happen. Compliance become less. So pulse pressure become high. So always remember the first point: stroke volume is directly proportional. Compliance is inversely proportional. Third component: heart rate. When heart rate is more, diastolic time will be less. Again, pulse pressure will be more. Pulse pressure will be more. Fourth point, peripheral vascular resistance when increases. Peripheral vascular resistance when increases, diastolic pressure will be more. So the narrowing will be happen and pulse pressure will decrease. Aortic valvular disease. In aortic regurgitation, okay, there will be backflipping of the blood, so stroke volume will increase, so pulse pressure will increase. On the other hand, in aortic stenosis, stroke volume become less, pulse pressure become low. So at least remember these points which are important for pulse pressure. Now, mechanism of transcutaneous electrical stimulation for pain management. What is the answer? Tense therapy. What is the exact answer? Inhibitory neurotransmitter, adrenergic receptor, gating, or supraspinal control. This is the famous question, tense transcutaneous. If you remember, my dear doctor, this is your spinal interneuron. Spinal interneurons. Okay. They releases endorphin. They releases endorphin and enkephalin to decrease the pain. To decrease the pain. Okay. And suppose you are not happy, you are having dull pain. Why? Because C fibers are stimulated. C fiber will inhibit spinal interneuron. You know that. Yes, answer is C. Very good. Answer is C. Most of you are correct. But if someone start massaging you, okay, or acupuncture, if there is acupuncture, they all will generate A beta fiber. A beta fiber will stimulate interneurons to release endorphin and decreases the pain. Why so? Why so, doctor? Because A beta are myelinated fiber. C fibers are unmyelinated. They are unmyelinated. Okay. So A beta will suppress, A beta fiber will suppress C fiber. Why? The myelinated. And this is called as which theory? Gating theory. Gating theory. Gating is happening at the spinal cord. Okay. So the TENS, transcutaneous electrical nerve stimulation, is also example of stimulation of A beta fiber. Clear? A and B in the graph below are representative of which of the following ion in term of permeability for action potential generation. What is your answer? This is RMP. This is your threshold. And usually this is because of sodium ion. This is because of potassium ion. Now, if you see this action potential, tell me which graph is showing permeability of sodium and which graph is showing permeability of potassium. This question has been asked from Genome. It is the exact image given in Genome. Anush Kumar Chaudhary, answer is A. Absolutely correct. Very good. In the exam, you cannot think an answer. Only if your repeated topics are very conceptually concrete, only then you can answer. See, depolarization is because of sodium. So we are having sodium permeability like this. And potassium permeability is like this. It will be after depolarization. It will be for repolarization. So if you see the A is showing sodium permeability and B is showing potassium permeability. B is showing potassium permeability. So it is a simple question. But you must know the diagram, only then you can answer. So answer will be A is sodium, B is potassium. Below are the two vessels shown. Assuming the pressure along the vessel is same and both of them have linear blood flow, what is the amount of blood flow in A compared to B? Diameter is 2D, it is D. Length is L, it is 2L. Now, what is the ratio of flow in A and B? This is A, this is B. Tell me the answer. Yes, SS, how will calcium look? Yes, what is your question? Please repeat it. We can discuss your topic after this question. How will calcium? Yes, what is the answer? So everyone is after 16. If you know the formula, flow is proportional to the R की power 4 by L. Some of you are saying B, some of you are saying D. See, radius is 2 times, the 2 की power 4. But length is also twice. This is the formula. R की power 4 by L. 2 की power 4 is will be 16. But length is also double upon 2. So answer is not 16, answer will be 8. Answer will be 8. Clear? You are not considering length. Length is also given, na? This mistake we keep on making. We only consider the radius. We forget about the length. So please do consider radius as well as the length. Clear, dear? And assess your question about calcium graph. My dear, this question is regarding sodium and potassium only. This is for action potential of your nerve and muscle, skeletal muscle, not the cardiac. Okay. And nerve and muscle depolarization is because of the sodium and re is because of the potassium. Okay. So this is the action potential of the skeletal muscle and clear. If you want to discuss at the end of the class about the action potential of SA node and all, we can discuss that. Myosin ceases to be in contact with actin filament as a result of. Now again, they are asking one question again every year from sliding filament theory. What is your answer, my dear? Dissociation of ATP and IP, cessation of calcium release, conformational change in troponin T, or attachment of ATP to myosin, who will cause relaxation? It is a repeat MCQ. Yes, BD. Okay. Okay, let me tell you the answer is D. Attachment of ATP to the myosin. When ATP is attached, it will dissociate myosin from actin. When ATP is attached, it will dissociate. Now let me see the diagram. Each and every step is very important for your exam. You cannot skip this diagram. See, until we have calcium, it is called as cogged position. The first position is called as cogged position. They are looking together happily, looking as if they are a best couple, actin and myosin, but there's a thin line of tropomyosin. Tropomyosin wrap around, let me zoom it. Tropomyosin wrap around actin filament. Tropomyosin help in contraction or relaxation. What do you think? Relaxation. Muscles are relaxed. They are not allowing actin and myosin to be together. What is this position called as? It is called as cogged position until we have calcium. Now, step number 2, question number 2. What happens when calcium comes? When calcium attaches to troponin C, it causes conformational change. It causes conformational change to uncover myosin binding site on actin. Initially, myosin binding site on actin are covered by what? Tropomyosin. Tropomyosin. So tropomyosin is covering the site. Only when calcium comes, it attaches to troponin C, cause conformational change so that actin myosin can come together. And this is called as, the third step is called as power stroke. Third step is called as power stroke. And the fourth step you can see here, when ATP come and attaches to the myosin, it will detach myosin from actin. It will detach myosin from actin. So when ATP comes, you can see here, myosin is detached. Myosin is detached. So please do remember these steps. It is very important for exam. The transport of iron into enterocyte is done by which of the following proteins? What is the exact answer? Transferrin, ferroportin, hepcidin, and divalent metal transporter. What is your answer, doctor? In the same question, if it is heme, then what will be the answer? There are two different MCQ. Iron transport into enterocyte is done by which of the protein? What is the answer? Everyone should answer. Yes, transferrin, ferroportin. Okay, let me tell you answer is DMT, divalent metal transporter. Okay, this question is very important from this diagram. Again, few diagrams are very important. Whatever iron we are taking, most of the iron are in ferric form. Most of the iron are in which form, doctor? Ferric form. So first of all, ferric will be converted into ferrous by ferric reductase or DCYTB. Now, this ferrous will be taken by DMT. What is DMT? Divalent metal transporter. Divalent metal transporter. Okay, this ferrous will be inside the cell. Now, again, this will be converted into the ferritin so that it will combine with transferritin combined with the ferric to form ferritin. Ferritin is the storage form. Ferritin is the storage form. Now, the second question which they have asked recently, if you are taking directly the blood, the heme, so how heme will be transported? Most of the doctors answered divalent metal transporter. That is wrong. Answer will be heme carrier protein. Answer will change. Heme carrier protein 1. Then answer is not DMT1. Reflexive, we are always knowing that they're asking about DMT1. Iron is transported in the duodenum by DMT1. Recently, in one of the examination, they asked heme is transported by. Then answer was not DMT, answer was HCP1, heme carrier protein. After that, whenever they need to go outside, they will go via port called as ferroportin. Ferroportin, whenever they are needed. And again, this ferrous will be converted into ferric by hephaestin protein so that they will be carried by transferrin. Each and every step is very important for your exam. Okay. Step number 1. Whatever iron we are taking is in the ferric form. It need to be converted into ferrous by ferric reductase called as DCYTB. This ferrous will be taken by divalent metal transporter. Again, when you need to store in the duodenal cell, it will be converted into ferric and combined with transferrin to form ferritin. Transferritin to form. It is also called as apoferritin. Apoferritin. Apoferritin with combined with ferric. Let me write in the bold red color, very important point. Which protein is there? Apoferritin. Apoferritin combined with ferric to form ferritin. Apoferritin combined with ferric to form ferritin. Okay. And they are, poisonous. We cannot throw in the blood. So there should be a tightly port. And that port is controlled by the hepcidin. This port is controlled by whom? From the liver, hepcidin. Hepcidin protein. It is called as a port, ferroportin. So only when it is needed, hepcidin will lose the control of ferroportin, iron will come outside, and this iron will again convert into ferric. Only then it can be transported in the car, and that car is called as transferritin. Okay, please pause this video, write this, and revise this because every protein is very important. First is divalent metal transporter, then apoferritin, ferritin, ferroportin, hepcidin, hepastacin, and transferritin. These all are your exam question regarding your iron transport in the duodenum. And the last question, which I told you, heme is transported by. It is not divalent metal transporter. It is your HCP, heme carrier protein 1. Clear? What does zero pressure indicate in pressure volume loop curve? What does zero pressure? Zero means atmospheric pressure. So when neither you are inspiring nor you are expiring, you are at resting condition, how much air you have? Residual volume, functional residual capacity, tidal volume, or inspiratory reserve volume. I have selected only those topics which are coming almost every year. And definitely they will come this year also. I hope if you see this video, at least you get 50% of question from these topics. Minimum. It can be more also. What is the answer? Residual volume. What is the amount of air right now in your lung? I don't know. This topic is coming every year for last 4 or 5 years, but even then we are making mistakes. Yes. Let me see how many of you are correct. Yes. What is your answer? B, A, D. D. Okay. Residual, functional. How much amount of air you all are having right now? Please don't forget. Please don't forget FRC, the most important capacity in your lung. This is the amount of air which everyone is having right now. FRC. I will tell you in detail, don't worry. It is also called as equilibrium volume. Okay. It is also called as which volume? Equilibrium volume. It maintains the equilibrium at zero pressure. FRC. Okay. How? Let me tell you. The amount of air you take in and out is called as tidal volume. The amount of air which you take above to this is called as inspiratory reserve volume. Amount of air which you expire above that is called as expiratory reserve volume. And the amount of air which you cannot expire is called as residual volume, even after forceful expiration. If we combine IRV with IC, it is called as inspiratory capacity. This is called as functional residual capacity. This is called as total lung capacity, and this is called as vital capacity. Now, amount of air after normal expiration. After normal expiration, this is the amount of air you have right now. Everyone is having this much. If you are not forcefully expiring, I hope you are not expiring forcefully. I hope everyone is in resting condition. They are not doing like that. Then how much air will be in your lung? FRC. FRC is called as equilibrium volume. When you are at equilibrium, neither inspiration nor expiration. It is the equilibrium. At this equilibrium, amount of air in the lung is FRC, not RV. RV is the amount of air after expiration. Clear? Even if you see this diagram from Harrison, okay, the middle curve is your lung plus chest wall. Okay, at 0 mmHg, how much is the pressure? FRC. FRC. Total is total lung capacity. Minimum is again residual volume. But normally it is FRC. It is FRC. This diagram is very important. I've discussed so many time in detail. Please go to the previous video to see this topic in detail. It will take more than 10 minutes to discuss that. Only I have taken this diagram to show you the middle one. The red one is for lung and thorax. The blue one is for chest wall, and the brown one is for lungs, compliance of lung. And to show you the equilibrium pressure is your what? FRC, functional residual capacity. Clear? The image shown shows the membrane potential during action potential. The region marked as DE is due to influx of sodium, efflux of potassium. Sodium what? What is the answer? It is an easy question. Just now we have discussed that. What is your answer, doctor? From D to E, what is done? This is your D, this is E. Yes, so everyone is correct. Yeah, this is sodium, and D to E will be efflux of potassium. Universally, repolarization is due to efflux of potassium. Efflux of potassium. And depolarization upstroke is due to influx of sodium. So no doubt in this answer is what? D, efflux of potassium. Compared with the apex of lung, the base of lung has, compared to the apex of lung, the base of lung has high pulmonary PO2. Question is regarding the base. High PCO2, higher V by Q ratio, or same V by Q ratio. What is the answer? Compared with the apex of lung, the base of lung has higher PO2, higher PCO2. Yes, Grace B, Kushi B, D, A. Okay, let me discuss. This is your apex. This is the base. Okay. Ventilation is maximum at base or apex? Tell me. Ventilation is maximum at the base or apex? What do you think? Answer is base. Why? Because they have smaller alveoli, so they can expand more. Base has smaller alveoli, so they can expand more, compliance will be more. Question number one. Question number two, perfusion is maximum at apex or base? Next question. Perfusion, the blood supply is maximum at the base because of gravity again. Perfusion is maximum at the base. Again, the answer is same. Ventilation is maximum at base, perfusion is maximum at base, but V by Q ratio is maximum at the apex. Why so? Because ventilation is less, but perfusion is very, very, very less. So ratio become high. Ratio become high. So if V by Q ratio is highest, oxygen pressure will be highest at the apex, carbon dioxide pressure will be highest at the base because of poor exchange. Now tell me the answer. Compared with the apex of lung, base of lung has high pulmonary PCO PO2? No. Lowest PO2. High pulmonary CO2? Yes. B. High V by Q ratio at the base? No. Low. Same V by Q ratio? No. It is low. So if you know this much, you can answer the questions which are related regarding apex and base. So once again, perfusion is maximum at the base. Okay. Ventilation is maximum at the base, but ratio is maximum at the apex. So if you see tubercular foci, you will see maximum at the apex. So PO2 will be maximum at the apex. And PCO2 is maximum at the base. Clear? So these are the questions which can be asked when you are in the standing position. What is the value of V by Q ratio and all? Which of the following substance has highest renal clearance? Which of the following has highest renal clearance? PAH, inulin, glucose, or sodium? I hope you have all have attended the test, these tests. Anyone of you having 20 out of 20? All of the questions are correct. Very good. Answer is PAH. Very good. Because clearance of PAH is equal to GFR plus secretion. It is equal to renal plasma flow. Maximum. Its clearance is maximum. Inulin has pH of clearance of inulin is usually equal to only GFR. Only GFR. Glucose usually not cleared in the normal condition because it is absorbed in the PCT. It does not pass beyond the PCT. So clearance is 0. Sodium, it is absorbed in the PCT again. Yes, 14 out of 20. Okay, you got 14 out of 20. Good. Even 14 is a good mark, 70%. Good. Okay, so answer is PAH, my dear doctor. Is this clear? Para amino hippuric acid. So Anuj, I hope I am clearing your doubt which you have in your questions which are wrong. Silly mistakes, yes. Which of the following cause a decrease in the renal calcium clearance? Hypoparathyroid, treatment with thiazide, treatment with furosemide, ECF volume expansion. Which of the following cause a decrease in renal calcium clearance? One cause a decrease in renal calcium clearance. Yes, I'm very happy because all of you are correct. Very good. Excellent. Hypoparathyroid. See, parathormone increases calcium in the blood. So hypoparathyroid means decrease calcium in the blood. Meaning what? Increase clearance of calcium. This is wrong. Yes, Anush, you are my student. That's good. Which college? Are you from Fatehpur? Okay. Second is treatment with chlorothiazide, hydrochlorothiazide. Thiazide blocks which channel? NCC, sodium chloride channel, and it decreases calcium in the blood. That is why it is given as a treatment of recurrent kidney stone. Recurrent kidney stones. Okay, you're from HIMS. That's wonderful. Nice to meet you after a long time. So, thiazides are the treatment of choice for recurrent kidney stones. Why? Because they will prevent calcium in the urine. On the other hand, furosemide causes increased clearance of calcium in the urine. So they are prone for kidney stones like Bartter syndrome. Furosemide is due to blockage of which channel? NKCC. Mutation of NKCC causes what? It is equivalent to Bartter syndrome. And NCC mutation is equivalent to Gitelman syndrome. Okay. So furosemide is just behaving like Bartter syndrome. Loop diuretic. They have loops so calcium will go out. Even in the Bartter syndrome, clinical presentation is what? Recurrent nephrolithiasis. So answer is, of course, answer is very correct. You are correct. Answer is B. Very good. That's wonderful. A lot of questions nowadays are coming regarding Bartter, Gitelman, Liddle syndrome, then Cone syndrome. This time also in the aims they ask these questions. A 49-year-old patient has undergone the heart transplant due to progressive heart failure. After transplant, cardiac response are recorded. Which of the following parameter does not change in the patient with exercise compared to the normal? So this is a simple question. It is coming also in NEET UG and NEET PG both. If your heart is transplanted, what is not done? Yes, you are correct, Anuj. DCT gentleman. Barter is in the TAL. Yes, Patel. LTEBEL. BGL. What is full form of this? Is it a mnemonic? Yes, so you know the answer. Answer is C. Heart rate. Yes, very good. So you know after exercise, because now vagus nerve is not there. Now the sympathetic parasympathetic is gone, so he cannot increase and decrease the heart rate. So answer is heart rate. It is a simple factual question after heart transplantation. A pyramidal tract is originated from which of the following area? So you know this is your beautiful brain. This is central sulcus, precentral gyrus, postcentral gyrus. It is the primary motor cortex. It is the somatosensory area. This is the supplementary motor area. So answer is very simple from all. Anyone can tell me from which area maximum motor neurons are coming. Primary motor cortex, somatosensory cortex, or supplementary motor. From which area maximum motor neurons are coming? This is again a often repeated MCQ, which has maximum motor neurons. For this answer is D, of course. But if they ask the same question and they just convert it into the maximum motor neurons originate from, then what will be your answer? Primary motor cortex is for idea generation. Somatosensory is for sensory motor integration. Supplementary motor is for bimanual coordination. Bimanual coordination. Yes, what is the answer? DAB. Yes, answer is B. Very good, Grace. Answer is B. 30% come from primary. Normally we guess primary. It should have maximum. No. 30% come from premotor and supplementary motor. But 40% of motor neurons originate from somatosensory area. We cannot guess this question until we know this fact. Whenever we are guessing, the primary motor should have maximum motor neurons. तो हम गेस लगाते क्या है कि प्राइमरी मोटर है तो सबसे ज्यादा मोटर न्यूरॉन्स यहीं से आएंगे. इट इज नॉट लाइक दिस. Primary motor neuron is cortex is the king area. It will give the idea. It will execute the movement. Execute the movement. Somatosensory area is for sensory motor integration, and supplementary is for bimanual coordination, and premotor is for posture setting. Premotor is for posture setting. Setting of the posture. So primary motor is for idea, 30% more neuron will come. Somatosensory area is for sensory motor integration, because sensory will go there and motor will come. This is also called a sensory cortex. So we are thinking sensory cortex may have less motor neuron. No, they have maximum motor neurons, because all sensory are coming to this area. Broadman area number 321. Primary motor cortex, Broadman area number 4. Lot of questions are from this topic. Broadman area number 4. And somatosensory area Broadman area number 321. 321 area is the area where all the somatosensory neurons are going, either from dorsal tract or from anterolateral, but motor neurons are also coming, and that to maximum. Maximum motor neurons come from sensory cortex, not from primary motor cortex. I hope you will not forget now. 1 marks can shift your rank from here to here. So each and every point, listen very carefully. I hope this point you will not forget. Primary motor cortex, Broadman area number 4. How many motor neurons? 30% motor neuron. Function is idea and to execute the movement. Somatosensory area, all sensory neurons will end here. Okay. And 40% maximum motor neurons will come from this area. Supplementary and premotor, 30%. Supplementary motor area is for bimanual coordination, and premotor is for posture setting. Setting of the posture. A 47-year-old post-menopausal woman visited orthopedic surgeon for chronic bone pain. Okay, raloxifene is given. This is a simple question. What is the answer, doctor? Reloxifene. Yes, Dr. Indu, you are correct. Very good. Most of you are correct. Okay, now I will ask you a question. Parathormone. Let me add one page, I think. Parathormone has receptor on which cell of the bone? Osteoblast. Bisphosphonate. Okay, I will tell you bisphosphonate क्या होते हैं. Parathormone is acting on which cell? Osteoblast or osteoclast? What is the answer? It acts on osteoblast, not osteoclast. Now they will release rank ligand. Normally we are thinking they are osteoclast because they will dissolve the bone. It is not like that. This rank ligand will act on osteoclast to dissolve the bone, to dissolve the bone and increase the calcium. So receptor is an osteoblast. Now rank ligand is good for bone or bad for bone? Now you will say it will be bad for bone. That is why osteoblast will also secrete osteoprotegerin. What is osteoprotegerin? Osteoprotegerin will inhibit rank ligand. Otherwise, it will cause osteoporosis. Osteoprotegerin will inhibit rank ligand. Otherwise, parathormone will cause severe osteoporosis. And estrogen also inhibit rank ligand. Estrogen also inhibit rank ligand. That is why for females, estrogen is good for the bone. That is why when estrogen become less, we will have post-menopausal osteoporosis. After the menopause, we can see post-menopausal osteoporosis. And you know the drug of choice. Which is the drug of choice? Anyone? You are correct, Anuj. You told me what is the name of the drug? Bisphosphonate. Bisphosphonates like ibandronic acid, zoledronic acid, alendronate and all. Alendronate. Good evening, Achan Khan. How are you? Alendronate. These will inhibit osteoclast. How? By inhibiting farnesyl pyrophosphate synthase enzyme. It is in the melanate pathway. You know melanate pathway? There is a key enzyme, farnesyl pyrophosphate synthase, that is inhibited by bisphosphonate. And you can also give estrogen receptor modulator, like I have discussed, and you can also give rank ligand antibody, denosumab. Denosumab. Okay. Then there is a dual drug which had dual action like strontium granulate. We can give estrogen receptor drugs, and also so many drugs can be given. And the side effect of bisphosphonate can be esophagitis. So we prefer giving it empty stomach. Esophagitis can be there because of bisphosphonates. Okay, so this is very important. Parathormone receptor is on osteoblast. Rank ligand will act on osteoclast. Rank ligand will act on osteoclast. And osteoclast will increases the calcium. Osteoblast will also release osteoprotein to prevent the bone, prevent the osteoporosis. Okay, so I hope this is clear. Answer is Raloxifene is a estrogen receptor modulator drug. It has same effect as estrogen hormone to improve the bone density. Etidronate is a bisphosphonate drug, inhibit osteoclast. Teriparatide is a parathyroid analog. So many drugs can be given. Yes, osteonecrosis is also a side effect. Very good. Now the last question. I think this is the last question. What is the answer? I hope you know about amacrine and Hargental cell. You know, off-center on phenomena. A medical student is studying the response of retinal ganglion cell to light focus on the receptive field. He identifies a cell to be off-center on surround. Off-center. Center is off. Off-center. Let me use the black. Off-center and on surround. You know, lateral inhibition as on surround. Okay. What mechanism is likely contribute to reduce the firing rate of ganglion cell when light is focused on the center? The center is off. When you are focusing on me, you cannot see the page. And when you are seeing the page, you cannot see the me. At a time, you can focus on one thing. तुझ पे ही फोकस है, दैट इज द सॉन्ग, सब धुंधला धुंधला लगे तुझ पे ही फोकस है. So when you are focusing on one cell, one thing, automatically periphery become blurred. It is called as lateral inhibition. It is called as lateral inhibition. Nowadays we are having portrait mode in the phone. It is causing blur. The periphery become blur and you become enhanced. That feature is in your eyes, and it is because of lateral inhibition, because of which cell? Horizontal cell. It is because of which cell? Horizontal cell. It is because of horizontal cell. Now you can see the answer. Lateral inhibition is caused by horizontal cell. So activation of nearby photoreceptors and excitation amacrine cell, no. Okay, answer is 4. Activation of nearby photoreceptor lead to hyperpolarization of the horizontal cell. So horizontal cells are important for lateral inhibition. So answer will be D. I hope I have cleared all the questions now. Okay, so we have cleared all the questions. If you have any doubt, any topic, you can ask me, or else you can revise the video, make it in the form of some notes. And I hope this will be helpful in your NEET PG examination. Okay. So I think no doubts are there. So thank you. Thanks a lot for giving your time. All the very best. Yes, you want me to say pre-potential. Okay. So let me discuss. It will take hardly 2 minutes. This is regarding pre-potential. So this is called as pre-potential, also called as pacemaker potential. This is called as depolarization. This is called as repolarization. Okay. Pre-potential is due to influx of, answer is T calcium, transient calcium, and slow sodium. Influx. Influx of T calcium. There are two types of calcium channel, T and L. And also, it is also due to decrease efflux of potassium. Okay. Now, depolarization is due to influx of L calcium. And Re is always universally due to efflux of potassium. These channels are called as funny current. I means current, F means funny. They are also called as HCN channel. HCN channel. HCN channel means hyperpolarization, hyperpolarization induced cyclic AMP dependent nucleotide channel. Okay. Now, one question was asked in JIPMER few years back. This is voltage gated or ligand gated? Answer is both. It is both. Voltage gated and ligand gated. So this is both ligand gated as well as voltage gated. And the blocker of funny current, ivabradine. Ivabradine can be given in those cases which are resistant to metoprolol. They are not. Some there is supraventricular tachycardia or fibrillation. Sometimes there is an increase in the heart rate, and they are not responding to the beta blocker. Then we can use ivabradine. Funny current blocker. Okay, so these are the questions which then can be asked regarding pacemaker potential. Is this correct? SS. Please to remember SCN is hyperpolarization induced cyclic EMP dependent nucleotide channel. It is voltage gated as well as ligand gated. Okay. Okay, thank you. Thanks a lot. All the very best. See you very soon in another session. For any doubt, you are most welcome to the DocTutorials group. You can ask your doubt, whatever you have, and I will try to answer. Take care. Bye bye.
Thank you, sir.